Good morning. Welcome to today's webcast entitled Clinical Utility of Genotyping for Cervical Cancer Screening with Dr. Michael Gold, Associate Professor and Director, Division of Gynecologic Oncology, Vanderbilt University Medical Center, Nashville, Tennessee. Following the talk, we'll have a short question and answer session. You can ask questions at any time during the presentation via the web using your Ask a Question box. If you should need technical assistance, type your inquiry into the tech support box on the left side of your screen and click the Send button. If you are disconnected from the webcast, you can log on again using the instructions provided to you for accessing this webcast. If you cannot log on for any reason, please call 877-843-9272. It is now my pleasure to turn the webcast over to your speaker, Dr.
Thank you, Kate. And thank you to all who are attending this morning's broadcast. We will be discussing the clinical utility of genotyping for cervical cancer screening. What I'd like to go over this morning is the importance of HPV 16 and 18 in the etiology of both high-grade cervical dysplasia, the immediate precursor of cervical cancer. We'll also discuss the evidence for risk stratification based upon typing for HPV 16 and 18, and then look at the guidelines that support the use of genotyping in current practice. I'd like to begin with a few polling questions to get an idea of what the audience is doing. For women 30 years of age and older, do you routinely recommend A, annual Pap testing, B, annual Pap and high-risk HPV testing, or Pap and high-risk HPV co-testing every 3 years? All right. Well, it looks like over half are continuing to use annual Pap testing, while others are using a combination of Pap and HPV testing, and some using the newer guidelines for every 3-year co-testing with Pap and high-risk HPV. We'll look at some of the data for this and guidelines for its use in a minute. My second polling question is for women 30 years of age and older whose screening results, if you do co-testing, are cytology normal or negative for intraepithelial lesion or malignancy, yet are high-risk HPV positive. In that case, do you recommend A, immediate colposcopy, B, repeat Pap and HPV testing in 1 year, HPV genotyping for 16 and 18 in order to triage patients, in which case, if they're HPV 16 and or 18 positive, you'd refer to immediate colposcopy, while all others would have repeat Pap and HPV testing in a year. Or, for those of you who do not do co-testing, pick D. Great. Well, it looks like some of you are doing genotype testing, and for those who are doing repeat Pap and HPV testing, we'll discuss the possibility and potential for triaging your patients by HPV genotyping. So there have been a number of major advances in cervical cancer prevention over the last 50 or 60 years. The Pap test was first introduced in 1939, and over the last 50 years has resulted in a 70% reduction in the incidence and death rate from cervical cancer. For instance, in 1950, there were about 60,000 cases of cervical cancer a year in the United States, and of course we're down to about 12,000. The advent of liquid-based cytology has also continued to reduce the number of deaths from cervical cancer. HPV DNA testing was first FDA approved in 1999. This technology allows the identification of women at high risk for developing precancerous cervical lesions while helping to reduce the subjectivity of cervical cytologic assessment. There are two types of HPV testing, of course. There's the high-risk cocktail, represented by hybrid capture 2 or Cervista HPV high risk, and also the genotype testing, such as HPV 16-18 genotyping with Cervista or the new Roche test. Now, the natural history of cervical cancer has been fascinating, and our understanding has changed over the last decade or so. When I was a resident, we thought that there was a very slow, predictable pathway from HPV infection to mild dysplasia through higher grades, ultimately to cervical cancer. But what we've learned is that it's really an HPV persistent infection that's important. So for most infections with HPV, there's a transient phase of infection which undergoes rapid clearance, usually within the first 12 months, without ever developing any type of cervical lesion. Other cases of infection may result in a mild dysplasia, CIN1, or even some CIN2 lesions, and some of these may progress. But other infections will persist, and those persistent infections may result in a mild dysplasia or may progress directly into a moderate or severe dysplasia, which, over a number of years, perhaps up to decades, can progress to cervical cancer. A lot of our information comes from the HPV vaccine trials, where we saw that within 2 years of initially being diagnosed with a high-risk HPV infection, many women will have a high-grade cervical dysplasia without ever having a mild dysplasia previously diagnosed. I like this slide a lot because it reviews over 20 different studies that compare the results of persistent HPV infection and the risk of developing CIN2, 3, or cancer with a variety of other groups. The group on the bottom are those studies that use the transient HPV infection as a comparator. This group on the top uses patients who are HPV negative as their comparator, and those in the middle right here use either HPV negative or transient infection as the comparator. And what you can see is that an infection, a persistent infection with high-risk HPV, affords a 15 to 30-fold increase in the relative risk of developing CIN2, 3, or cancer compared to any of these groups. But it's not just an infection or even a persistent infection with high-risk HPV that's important. This series from Burkhoff demonstrates that certain groups of HPV high risk are even higher risk than the others. So for instance, if you look at the second grouping of columns right here, those patients infected with HPV 16 or those patients infected with HPV 18 are at much higher risk of developing CIN2 or more or CIN3 or more compared to this group here, which are the other high-risk HPV types other than 16-18 that are contained in the HPV high-risk cocktail. This is a classic paper by Michelle Kahn where she looked at women enrolled in the Kaiser Permanente system who had an initial HPV test on day 0. And what we see is that if we follow those out, those who were not infected with a high-risk HPV infection on day 0 had about a 0.8% or less than 1% risk of developing high-grade CIN3, carcinoma in situ, or cervical cancer over 10 years of follow-up. That's compared to about a 3% risk for those who were infected with high-risk HPV infections other than 16 and 18. But those who had an infection with 16 or 18 on day 0 had the highest risk of ultimately developing a CIN3 or cervical cancer. As you can see, the risk over a 10-year period for HPV 16 infection approximates 17%, and that for HPV 18 was approximately 13.5%. So 16 and 18 were both significantly more risky than any of the other high-risk HPV types. The other thing that you can see from this graph is the time frame in which high-grade dysplasias develop. With HPV 16, for instance, the onset of high-grade dysplasia following infection is much more rapid than with any of the other high-risk HPV types. This next slide shows much the same thing. In this, from Phil Castle and the NCI, you can again see that infection with HPV 16, followed by HPV 18, was much more likely to result in a development of CIN2, 3, or cancer compared to any of the other oncogenic but non-16-18 types, and certainly compared to infection with a non-oncogenic or oncogenic HPV negative population. And again, you can see that the HPV 16 is associated with the most rapid development of high-grade dysplasia. This is data coming from the SUCCEED trial being performed at the University of Oklahoma at present, where over 1,700 women were enrolled to identify endpoints and determinants of cervical cancer and high-grade dysplasia. What was seen is that almost 50% of CIN2 was attributed to HPV 16, the most common HPV type. 72.5% of all CIN3 was attributed to HPV 16, again the most common type. And among cervical cancers, 55% was attributed to HPV 16, and in this case, HPV 18, the second most common type, was felt to be the cause of another 14% of all cervical cancer. That data is very similar to other series, such as this one, where we see that 55% of cervical cancers in the United States were attributed to HPV 16 alone, while 76% were attributed to the combination of 16 and or 18. So again, HPV 16 and 18 continued to demonstrate themselves as significantly highest risk. That also holds true for the adenocarcinomas. In this series, looking at worldwide data, you can see that HPV 16 was most common among adenocarcinomas of the cervix, accounting for about 43%, while HPV 18 accounted for 32% and was significantly more common among adenocarcinomas than among squamous cell carcinomas. Other contemporary series show similar results with slight differences. In some cases, HPV 16 and 18 are equal, and in others, HPV 18 actually surpasses HPV 16 in its importance. But throughout these studies, the group of patients who have an adenocarcinoma caused by either 16 or 18 varies anywhere from about 75 to 80%. So Cosette Wheeler looked at SEER registry data from the University of New Mexico, and what she found was that cervical cancers caused by HPV 16 and 18 were more prevalent in younger women than invasive cancers caused by the relatively less high-risk types of high-risk HPV. What she and her colleagues suggested was that these less carcinogenic HPV types may require additional time to cause progression, and that these weaker carcinogens may be dependent upon secondary risk factors leading to the multi-hit hypothesis of carcinogenesis. This keeps in line with the trials we've just seen by Castle and Michelle Kahn, where HPV 16 and HPV 18 caused a more rapid development of cervical cancer compared to the other less oncogenic high-risk types. So with this information in mind, several societies have come out with statements regarding the importance of HPV genotyping. The SGO, for instance, says that HPV typing for the most common types of HPV disease, 16 and 18, is not only available, but that this should be viewed as an important additional diagnostic and screening tool. The SGO did note several caveats, however. First, these tests should not replace other cervical cancer screening methods, including regular Pap testing and gynecologic examinations. And secondly, that HPV testing and HPV genotyping should not be used as any form of a pre-screening tool prior to administration of an HPV vaccination. ACOG also came out with a society statement and recommended that DNA testing specific for 16 and 18 can be used as an adjunct in a specific population of women, and that is those who are cytologically negative but who have tested positive for any cocktail of high-risk HPV, which would be either 13 or 14 HPV types. They can then be triaged into groups who are 16-18 positive and those who are 16-18 negative. So what is the clinical utility of HPV genotyping and how would we use it in our populations? Well, first, genotyping can help us to stratify. It can take a group of women who are cytologically negative but who test positive for high-risk HPV and can help to stratify them into a group who's at higher risk for development of a precancerous lesion versus a lower risk group. We can then use that information to triage those women who are at highest risk towards a more aggressive clinical management strata or schema in which immediate colposcopy is performed, compared to those who are at lower risk who can be prioritized for follow-up with repeat PAP and HPV testing in a year. As soon as the FDA approved HPV genotyping, the American Society of Colposcopy and Cervical Pathology came out with a genotyping algorithm. What they said was, for this group of women who are cytologically negative but who are high-risk HPV positive, those who are 16 and 18 positive and therefore represent the highest risk group should undergo immediate colposcopy, while all other women can be triaged to repeat cytologic and HPV testing in a year and can be reassured that they're at lower risk. What this allows is for time for spontaneous resolution of the HPV infection and may avoid colposcopy altogether. Those who are both negative for cytology and HPV testing 1 year later would go on to routine screening in 3 years. Those who are persistently HPV positive, even though their cytology remains negative, should go on to immediate colposcopy. And of course, those who have developed a cytologic abnormality would go on to management per ASCCP guidelines, which generally consists of colposcopy. So one might ask what percentages of the population undergoing co-testing would fall into this category. From this data, you can see that of about 10,000 women undergoing routine co-testing at age 30 or older, about 7% tested positive for high-risk HPV but were cytologically negative. Among those, 20% were found to be positive for HPV 16 and or 18, and those would go on to colposcopy, whereas the other remaining 80%, who are high-risk HPV positive but HPV 16 and 18 negative, can be reassured and go on to repeat testing in 1 year. And again, about half of these women will clear their HPV infection during that time frame and not need colposcopy at all. So the addition of genotyping for this group of women helps us to determine who needs most aggressive management, limits referrals to colposcopy to only those at greatest risk, reduces the time to colposcopy by 1 year for this grouping of women at highest risk, and allows for reassurance of the other group of women that they're likely to clear their infection and may not need colposcopy at all. With that data in mind, I'd like to use a couple of case studies to help underline the use and utility of HPV testing and HPV genotype testing. I would like to say first that these represent case studies. They are examples of how we may use HPV testing and typing, and in no way represent the ultimate answers for how things should be done. So again, I'd like to go to some polling questions that I asked these. Our first case study would be of a 25-year-old woman who is undergoing routine screening and is diagnosed with an ASC-US pap smear. What's the most appropriate next step that you would perform in your practice? Is it repeat cytology in 6 and 12 months, undergo immediate colposcopy, test for high-risk HPV, or undergo HPV 16-18 genotype testing? All right, well, it looks like the numbers are reaching some steady state, and the majority of you would do high-risk HPV testing, whereas another quarter to fifth may do repeat cytology in 6 and 12 months. Well, the ASCCP algorithm provides us with either alternative. Particularly for those who have had a conventional pap smear and not liquid-based, then repeat cytology at 6 and 12 months makes the most sense. From the ALTS trial, it was suggested that the most cost-effective mechanism for those undergoing undergoing liquid-based cytology who have an ascus pap smear is to use HPV DNA testing for triage, and those who are high risk go on to colposcopy. In either grouping, about 55 to 60% of patients will ultimately end up undergoing colposcopy. The use of HPV DNA testing allows for that group to be identified sooner rather than waiting for a repeat abnormality at 6 or 12 months. I'm glad that no one picked HPV genotype testing for this population because that's not been looked at before, and most importantly would miss all of the patients who are 16/18 negative but otherwise high risk positive who have abnormalities that would not be evaluated. Our second case study looks at a 30-year-old woman with no history of abnormal pap smears in the past who undergoes co-testing. This returns cytologically normal, but tests positive for high-risk HPV test. And what I'd like to ask is, what's the most appropriate next step for this woman? Should she undergo colposcopy, repeat cytology and high-risk HPV testing in 12 months, genotyping for HPV 16/18, or routine screening at 3 years? Well, it looks like I've convinced most of you that HPV genotyping for 16 and 18 would be an appropriate method for triaging this patient population. Some of you still want to follow the guidelines of repeat testing in 12 months with both HPV and cytology, and it looks like a couple people felt that colposcopy would be the most appropriate choice. Remember that the ASCCP has recommended that use of HPV DNA testing as an adjunct in this population will traditionally allow us to either repeat both tests at 12 months if they're HPV positive at present, or triage them with 16 and 18. If they're 16 and 18 positive, then those patients would go on to immediate colposcopy, and those who were 16 and 18 negative would be reassured and go back to the repeat both tests at 12 months arm. So, assuming that we did reflex this patient and her HPV 16/18 comes back positive, what would be the appropriate step? Repeat cytology at 12 months, repeat cytology and high-risk HPV testing at 12 months, immediate colposcopy, or routine screening at 3 years. I think somebody was playing with us on that last spot, but it looks like everybody has a good short-term memory recall, and according to guidelines, it's colposcopy, immediate colposcopy. So again, reviewing the guideline. For those patients who are cytologically negative and who are HPV negative, current guidelines recommend repeat screening no sooner than 3 years. For those who are cytologically negative but HPV positive, it's recommended to either repeat both tests at 12 months, in which case persistent HPV positive patients would go on to colposcopy, those with cytologic abnormalities would go on to colposcopy, and those who are both negative would go on to routine screening at 3 years. Or we can follow the genotyping algorithm, and if they're 16/18 positive, they go on to immediate colposcopy, 16/18 negative have a repeat test in 12 months, and again, if by that time they've cleared their infection, they can go on to routine screening in 3 years. Those who remain HPV positive would undergo colposcopy, and as well as those who have a cytologic abnormality. So to conclude this portion of the discussion, hopefully I've demonstrated that HPV 16 and 18 are the largest attributable factors for the causation of HPV high-grade lesions, resulting in about 50% of all lesions, of invasive cervical cancer, 75% of invasive cervical cancers, and about the same proportion of adenocarcinomas. Infection with 16 and 18 strongly predicts subsequent diagnosis of high-grade dysplasias of all degrees, which carries through for up to 10 years of follow-up. Co-testing in women 30 years of age or older allows physicians to help identify those women at highest risk for development of high-grade cervical dysplasia and cancer, and can provide reassurance for those who are not 16/18 positive that they can wait one more year, repeat their co-testing, and have about a 50% chance of clearance of their infections. The first question asks my thoughts about HPV being used as primary screening test. And that's a very interesting question and a look towards the future. Certainly the data out of Europe, South America, Asia, and the Indian subcontinent suggests that HPV testing with cytology triage, rather than cytology testing with HPV triage, is likely to be more effective, or at least equally as effective, as cytology initially. At this time, however, we have not made a commitment to switch to this in the United States, nor has it been adopted anywhere else in the world. We'll have to await further research looking at which HPV types should be screened for initially, but I think ultimately we're very likely to move towards an HPV primary screening modality. The next question asks, if I'm performing PAP with reflex high-risk HPV for all pregnant patients, or do I still apply the new guidelines and perform a PAP with high-risk HPV testing? And continues, do I perform PAP smears on all patients who are pregnant? What if they've had a prior PAP negative and HPV high-risk negative within the last 2 years? And so that's a very interesting question. I recommend that all patients who are pregnant undergo PAP testing, unless by guidelines such as this, if they've been double negative screened within the last 3 years, they probably don't need another PAP test. In many situations, because our pregnant patients all have insurance, this oftentimes offers us the opportunity to perform a test when they may lose insurance afterwards. So many people prefer to perform testing regardless. But I think if a patient has been adequately screened previously, then a test is not necessary. In terms of high-risk reflex testing on pregnant patients, I would do that. I would perform that for triage of an ascus pap smear. And for those who are 30 and older, I think it also makes sense that you could use that to determine who, with a normal screen, should undergo further evaluation with colposcopy or repeat evaluation a year later. The next question asks, can we test patients who are 30 years of age or older with HPV 16 and 18 genotyping rather than doing the HPV high-risk cocktail with their pap smear? And I'm glad that this was asked. Remember that according to the Society of Gynecologic Oncology guidelines, the genotyping should not replace any current method of screening or evaluation. If we only test for 16 and 18 in this 30 and older population, remember, of those who would have been found to be high-risk positive, 80% of them are positive with a type other than 16/18, and as many as half of those will be persistently positive a year later. And that group is at equal risk for having a high-grade dysplasia as those who are 16 and 18 at this time. So no, I would not recommend use of genotype testing rather than doing high-risk testing. It's appropriate to do the high-risk testing first, and then if you want, triaging those who are high-risk positive into a group who are 16/18 positive who should undergo immediate colposcopy, and into a lower risk group who are 16/18 negative but positive for the other high-risk types who would undergo repeat HPV testing and pap smear testing in a year and referral to colposcopy if either of those are abnormal. Someone asks what impact genotyping will have on referral rates to colposcopy and further clinical management. Well, if you accept the default that in these women who are 30 and older, who are HPV high-risk positive but cytologically negative, if the default was to perform repeat testing in a year and only referring to colposcopy those who are either PAP or HPV high-risk positive at that time, doing
a second reflex test with genotyping for 16 and 18 actually brings to the forefront a group who are at higher risk and sends them to immediate colposcopy, while the remainder still have their high-risk testing performed again a year later, and those who would have been positive will still be positive, and ultimately, therefore, the same amount of women are referred to colposcopy. It's just a matter of finding those who are at highest risk and evaluating them sooner. The next question is type 16 mostly associated with adenocarcinoma and type 18 with squamous cell carcinoma. The answer to that is that HPV 16 in general is the most frequent type in all grades of cervical dysplasia and in most series in all types of cervical cancer, whether it be squamous cell or adenocarcinoma. Proportionately, HPV 18 is more important in adenocarcinomas than it is in squamous cells, but studies will say that either 16 remains more common than 18 in adenocarcinomas, that they are equal, or maybe 18 is slightly greater than 16. But for the most part, if you remember that 16 is most important, it'll cover you for all types of dysplasia and all types of cervical cancer. The next question asks, what percentage of women have CIN2 or greater if their reflex genotype testing is positive? And overall, if their test is positive, it's probably in the neighborhood of 15%. Remember that all those who are high-risk positive but cytologically negative have about an 11% risk of having high-grade dysplasia. If you pull out those who are at most risk, it's the women who are 16-18 positive. Their risk is about 15%. The remaining group overall, about 5%. And then if you wait a year, those who are persistently positive for the other HPV high-risk types, that increases that group to about 10% risk of having a high-grade cervical dysplasia. Our next question asks, what will the impact of HPV vaccines likely be on the incidence of 16 and 18 infections over time? Well, as you can imagine, as we eradicate hopefully 16 and 18 infections, those will decrease. Hopefully the number of cervical dysplasias will not increase. We've seen no evidence that the other high-risk types will fill the gap left behind by the lack of 16 and 18. What will happen is that the positive predictive value of cervical cytology will decrease as the number of lesions decreases. That makes future HPV testing even that much more important as a high-risk cocktail and even as a 16-18 triage. And it looks like, well, there we go, here's one more. In nullogravid patients with CIN3, do I perform LEAPs on all these patients, or do I perform PAP and colposcopy at every 6-month intervals? Well, certainly things have changed, and again, I won't suggest that the way I manage these patients would represent that of the producer of this webinar. Traditionally, we've recommended treatment of all women with CIN3. As we've discovered that treatment, whether it be cryotherapy or LEAP excision or cold knife cone, has future impact on fertility, we've moved away from treating everyone and moved towards more and more conservative management. At the present time, women who are CIN2, who are 20 years of age or younger, are recommended to undergo conservative management. And in my current practice, I've extended that to all nullogravid women or women concerned about future fertility with a CIN2 lesion. Certainly in young nullogravid women who appear to be compliant with their follow-up and who have small lesions, I think it's very reasonable to follow this group with repeat evaluations of both pap smear and colposcopy at 6-month intervals. Some of these women will clear their lesion, others will have a persistence or an enlargement, and both of which would undergo surgical excision. But for nullogravid women with large cervical lesions, those that are 2-quadrant or more, I still recommend treatment with a LEAP. There has been some data in the past looking at infertility related to cervical dysplasia, and that although it's not clear cut, there is an increase in infertility amongst these patients, and so probably treatment has about the same effect as leaving that dysplasia alone. One question about the necessity to test for low-risk HPV types. I'm glad somebody threw that in. There are no current guidelines from any society as to any use or utility for low-risk HPV testing. It doesn't affect our management. It should not be used to determine who should be vaccinated. It should not be used to determine who would go on to further testing or further evaluation. Because remember, infection with a low-risk type really affords no greater risk of developing cervical dysplasia or cancer as does not being infected. So no, really there's no necessity or utility for testing for low-risk HPV types. In a young patient, how long does it normally take CIN3 to progress to cervical cancer? And fortunately, we really don't know because people haven't done longitudinal studies watching CIN3. We do have some data from a couple of series where physicians thought that they could determine the difference between CIN3 and carcinoma in situ, or CIS, where patients were followed longitudinally, and up to a third of those patients developed cervical cancer, regardless of whether it was called CIN3 or carcinoma in situ. First off, that led to the discontinuation, really, of management decisions based on this and the lack of use of this differentiation. As far as how long does it take, it probably takes years to decades. However, in every literature series, there's always that small group of what we would call rapidly progressive cervical cancers where someone develops a cervical cancer after only a few years. There was a recent case report of a 19-year-old who had an advanced stage cervical cancer. So clearly, HPV infection can lead to cervical cancer in under 2 decades. And so it's probably not appropriate, if you're going back to the question about conservative management of women with CIN3, it's probably not appropriate to follow these women for more than about 1 to 2 years without performing some sort of treatment. All right. Well, that looks like it's the last of our questions, and we're about out of time. I'd like to thank all of those who joined in this afternoon, and particularly those who participated in the polling and in submission of questions. I hope you found this informative and helpful, and I hope you have a great afternoon.